As two practicing physician assistants, we've seen a lot and we've heard a lot. We know that you've heard a lot too. We are here to help you navigate through the BS by having open and honest conversations with other practicing professionals. I'm Heidi.
And I'm Cassie, and welcome to Mindfully Woman.
Okay, let's do it. Ready? All right. Hello, and welcome back to another episode of Mindfully Woman. We are here today with a wonderful episode planned for you guys. We're switching it up a bit.
Yes.
We are switching out from breast and cancer and risk reduction, and we're going into menstrual cycles.
Yes, I can. My 12-year-old self would be just so nervous talking about periods.
Yes, I agree. So we're kind of going to go in a stepwise approach today where we're going to talk, and we are doing bare bones today. We're keeping it basic. This is just a little introductory episode into like reproduction and hormones and everything that'll come down the line here. But we're going to go through, the early stages, like starting period, and then kind of what perimenopause, premenopause and perimenopause looks like, and then menopause, and basically like the symptoms that roll along with each. So
yeah. I love it.
Yeah.
Let's get into it.
To get started, basically the very first period a woman has is when they achieve menarche.
Yeah, that's the technical term, menarche.
Yeah, which is menses is the fancy word for that.
Yeah.
But this happens really for young girls anywhere between age 11 to 14, although sometimes we see it a little bit younger and a little bit later. But this is that defining moment of a transition for a child into adulthood.
Yeah, and I don't know if you've heard lately, but I have been hearing accounts of girls starting it like at 8,
yeah,
9.
I was going to say 9.
I can't even imagine. And so I don't know what's changing, but...
Diet. Hormones pumped up in our chicken. Seriously,
all the things. But yeah, no, I completely agree. And so it's very interesting. And I would like to see, if we could get more data on it, or I don't know what pediatricians are noticing. I haven't looked much into it, but I just have heard from patients that their daughters are starting younger, or people that they know are starting younger. So
yeah,
I'd be curious to see something come out of that.
I think we're trending more young versus like older.
Yeah.
Like younger age onset of periods versus older age onset.
Yeah,
which
absolutely
is more exposure to hormones too over your lifetime when you're starting at a younger age, which is kind of interesting to think about.
Uh-huh. Add that to the risk. Anywho, not the topic of this conversation.
Anyways, we've already talked about risk. But when we're born, as a female, we're born with a finite number of eggs in our life. So the eggs we were born with is basically what we were developed with in the embryo in our mom. And that is what we have for the rest of our life when we're born. And so the most common woman is born with 1 to 2 million eggs.
Yes.
Is that right?
Yep, that's correct.
And then by the time that a girl hits puberty, she has about 300 to 500,000 eggs left. But only about 400 to 500 will actually be ovulated, and many lost to just cell death over their lifetime.
Which is wild. That is such a stark difference in numbers.
Yeah. It's like a drastic drop off as time goes on.
Yeah. And so I was looking more into it, and only, like you said, only 400 to 500 are actually ovulated, where that is the chance that you could potentially have a baby. But the rest is just lost to cell death.
Yeah.
They just die. They don't function properly, or they're not able to actually be released. Who knows what? But
nothing ever happens with them.
Yeah, nothing ever happens with them.
Yeah.
And so when we say eggs, we'll do a little anatomy lesson.
Not chicken eggs.
But not chicken eggs. We're talking about these little tiny eggs that are in your ovaries. And so you have 2 ovaries that they tend to alternate which one releases an egg. And so then you have your ovaries, and then you have tubes that connect your ovaries to your uterus, which are called fallopian tubes. They're like the little slides for these eggs to go down into the uterus. And the uterus is then the organ that the egg can actually attach to, and that's where, of course, a baby grows. Am I missing anything?
No, that sounds perfect. And then, of course, you got like the cervix at the bottom of the uterus, which is where a baby would deliver through.
Yeah, and that's where we do PAPs.
Into the vagina. It's a vaginal canal. So that's kind of internal to external, what things look like for a woman reproductively.
And I will add, so the ovaries are what is stimulated by hormones or releases hormones itself. And those ovaries tell your uterus what to do.
Yes.
And so if you were to have your uterus removed, your ovaries are still functioning. Your ovaries are still releasing hormones. But if you remove your ovaries, your uterus isn't doing anything. It's just hanging out in there.
Yeah, doing nothing.
Same with the fallopian tubes.
Yeah. No, I think that was really good. A great anatomy lesson for the day.
Thanks so much.
And we will put a picture on too, so you guys can see what that looks like as well.
I think that's a great idea.
So we kind of have the anatomy and how that works and kind of starting periods. And then we kind of jump into our reproductive years. So just to kind of talk through, we start a period as a younger girl in our lifetime. And typically those periods are a little bit abnormal. And that can be for a few years until a woman kind of really hits her stride with periods. So they could be irregular, they could be a little heavy, they could be a little light. And then they normally start regulating out where they are typically on like an every 28 to 35 day cycle. That is the most common regular menstrual cycle for women. But you could kind of like girls starting periods earlier, you could have some women who maybe have a period every 21 days, or those who are like set on every 36 days. There's a lot of transgression in how long it would be, but a cycle is, first day of bleeding is day one of the cycle, and then it resets until you bleed again to the next cycle. And that's how you get the track of that.
And you can bleed for 3 days, 7 days, 10 days. So it really is just dependent on your personal cycle. And then too, like you can have variations in the length of your cycle. And that's usually, it seems like when OBGYNs get concerned, whenever it's over 30, like if you go 40 days, 55 days,
yes,
in between your periods, that's when it starts to go, that's not really normal. But if you're a constant, 35 days, 35 days, 35 days, then that seems to be okay.
Yeah.
Yeah.
And your ovulation period is probably, somewhere set right in the middle of that month versus like you were saying, if you were doing, a 28-day cycle and then you have 40 days until your next one and then 60 days until your next one, there's probably something going on that you definitely need to talk through with your OBGYN to figure out, are you ovulating regularly? Are you not? What do we need to do to kind of check things out with your cycle in your body?
Yeah,
because most commonly, I would say women tend to ovulate around day 14 of their cycle.
On like a perfect like 28-day cycle.
Yes, perfect 28-day cycle. Textbook anatomy woman with like everything going well. 28-day cycle, you're ovulating kind of midway through that around day 14. And so ovulation is that period, like Cassie was talking about earlier, where you release the egg and it gets taken up by the finger-like projections on the fallopian tube up into the fallopian tube. And that's that window of time for a woman where you can get pregnant.
Correct. Okay. Yeah.
But with women and ovulation, that egg life is pretty short. Like it's around...
And what did we say? Like 1 or 2 days?
Yeah. It's about like a full day total, like 12 to 24 hours.
Yeah.
And so when you think about becoming pregnant and insemination, so when the sperm enters the egg, that really, sperm can last a lot longer than the amount of time the egg can last. So let's say that a woman may have had intercourse, 5 days before she ovulated. Sperm can last up to 5 days. So you could get pregnant, based on having intercourse 5 days prior to the time that you actually ovulated.
Okay.
So, of course, if you're having intercourse regularly to try to get pregnant, it's hard to tell, on what day that would have happened. But just kind of interesting to think about if you're somebody who is trying to get pregnant.
Yeah. So there's a lot of reasons to pay attention to your ovulation cycle.
Yeah.
Well, of course, like you said, getting pregnant, that is something that we call family planning, where you monitor your symptoms of ovulation and it just increases your chance or increases your odds of actually getting pregnant. But then also for symptom control, weight management, things like that, making sure that your hormones, which actually cause your ovulation and then other hormones then to cause your period, trying to get those in line can also help balance out other hormones as well.
Yeah.
Right?
Agree.
So
yeah.
There's a lot more reasons to pay attention to your ovulatory cycle and your periods than just getting pregnant. Depending on symptoms, of course. Yeah.
And there's so many ways to track ovulation too.
Yeah, really, it's wild.
It's wild. So there's so many apps out there. Like personally, I like the Flow app, FLO. There's a pretty standard cheap version where you just track your cycles. I don't pay for anything fancy, but I just like to keep track of kind of like what things look like for myself. So I personally use that app, and there's so many different ones out there. Like I think there was one called like Ovia and Clue, which were different apps for more like calendar tracking. And then there's of course just like tracking on the calendar, just kind of like mapping yourself and saying like, okay, like put on your, Apple or Google Calendar. Like I started my period this day and the next month I started this day. And that'll also give you a good idea of how your cycles are too. But there are so many other things out there that I personally can't speak to as much versus like what an OBGYN could, like basal body temperature monitoring. I think you have to be very specific with it.
Yeah, that's like I think every morning when you wake up.
Yes.
You have to take your temperature.
First thing in the morning.
And you have to be very diligent and just very observant with it, because it's like very small changes.
Yeah.
Just based on what I've read. But
it's like minute. I said, I don't know enough about it. And you have to be a person that is very diligent and scheduled.
Yes.
And I don't think I personally am that diligent and scheduled, but
I am not.
There are plenty of other people that are.
Yeah.
So if that works for you, go for it. But like I said, of course, talk to your medical providers about it.
It's a cheap, easy option.
Cheap, easy option.
Yeah. To try.
Another cheap, easy option is like literally looking at your discharge.
Yeah.
So kind of monitoring like your cervical mucus. So around the time a woman ovulates, most commonly your vaginal discharge is more like thin, like call it egg white consistency, kind of more like sticky and stretchy looking. That's another way people have monitored, but not everybody is perfect that way either. I know some women, when they ovulate, some might have like a little bit of spotting or light spotting. So it's not, it's not perfect. In those situations too, you kind of wonder like, is there, some kind of like cyst or free fluid in the pelvis, but, just some other ways to track ways that you're ovulating or when you're ovulating too.
And it seems like these apps too, you can track those things as well. And they give
your symptoms.
Yeah, like your symptoms, and they give you definitions of, okay, well, what does this type of cervical mucus mean? What does it actually look like? What is my body telling me? So that's one thing you can absolutely follow. And side note too, something like an IUD, where you're not having periods, you still ovulate. So then you still have you can still have these symptoms of ovulation or these change in cervical mucus. And so if you're more looking at it from the sense of obviously not trying to get pregnant, but for symptom management or weight loss, things like that, then you can use some of these other telling signs that your body is
changing and going through a hormonal shift.
Yeah,
of the
absolutely.
Month. Yeah.
So it's pretty remarkable, really.
It is remarkable. The human body is fascinating, but the women's body is
holy cow,
even so much more fascinating and honestly confusing at times, because everybody is so different too.
Very different. And there's things too or disorders or diseases too that you might not be ovulating. And so then that's a whole different rabbit hole, and you can get a lot of different symptoms from that. So one that a lot of women know is PCOS, or polycystic ovarian syndrome, and that is a whole gamut of abnormal hormone fluctuations. And so a lot of times you don't ovulate with that.
Correct. And it can be really hard for those women to get pregnant.
Very much.
And so sometimes they have to take medications to try to stimulate the ovaries and to help them ovulate better. Also to, with that, and some women who do have PCOS, not all of them, but weight is also a thing they struggle with too. And we know too that certain weight disorders, so like women who are really, really thin, or those who are overweight or who have fluctuated with even eating disorders, sometimes they don't ovulate either. So it can be hard for those women to get pregnant as well. And also those that have like thyroid dysfunction. It is also so wild how our thyroid manages so much with our hormone balance as well too.
Absolutely.
So women who have thyroid issues can sometimes struggle. And there's also like genetic anomalies that can happen, unfortunately, as women, were born that you just can't quite control. So all of those things can make it really difficult to get pregnant. And I'm sure there are many others out there that we haven't said, but yeah, it's not just like a, one size fits all for everybody and try this and it's going to work perfectly. Like it's very different based on your unique situation.
And of course too, there are birth controls out there that obviously can prevent pregnancy, but also manage or help with ovulation or manage symptoms of what am I thinking? Of PMS.
Oh yeah.
Yeah. So there's a lot more reasons to use hormones than just preventing pregnancy. But I don't know about you. Also, side note, I feel like I've been seeing a lot more trend to getting off of birth control.
I have as well.
Not being on it, managing your symptoms in other ways, a lot more push for change in diet, and change in your sleep cycle, all sorts of things. I don't know. What's your thought on that?
I agree. I've had a lot of younger girls that I've seen more for just high risk stuff recently, or just some random things. They've talked to me a lot about how they've been on birth control for, a long time, since maybe they were a teenager. But they did it because, maybe they didn't like that their cycle was heavy back then, but they didn't really understand it. And so now, they're getting off of it and they're just trying to kind of let things happen as they will. Or maybe they're trying to get pregnant and letting their bodies regulate. But I've, seen a lot more push for women to get off of birth control, which is not a bad thing, because there's been some things I've heard and read that being on birth control for also a really long time can suppress things for a really long time, and it can take your body a while to adjust to getting back to your new normal, so to speak.
I mean, that makes total sense, because it's just changing our hormones in general, or even just having shifts in our weight impacting our hormones, and then how long that takes for us to our bodies to get used to it. Makes total sense.
Exactly. Me. I also have heard too, it takes your body roughly about 3 months, on average, to regulate off of birth control too, to kind of get your body used to that normal ovulation cycle. So women who want to get pregnant and maybe they've been on birth control for a while, don't get discouraged if you've, been trying right off the bat of stopping birth control. It may take a little bit for truly your body to get to a new normal for you. But it's if you're, 6 months, a year and a half, 3 years out where things aren't getting regulated, definitely I would seek some help from your OBGYN. But
agreed.
Yeah, we could talk about birth control too in a big episode, which hopefully we are going to do that soon.
Yes, that is definitely a goal. There's a lot out there, a lot to choose from out there. So
definitely,
I think that'd be a great topic.
With birth control too, I think we talked about symptoms and pregnancy, but also they're really good for period management. If women are having super, super abnormally heavy periods, or bleeding really bad, or maybe they're anemic, or they're needing iron infusions or something like that. I will say, birth control does have its pros and cons, but that's also another thing that people can use it for.
Or even like severe cramping, sometimes like ovarian cyst, right? So different things like that as well. Not as commonly the cyst, I suppose, but
so because sometimes you can get cyst on or off of birth control, depending on how your body reacts. So it's a fine balance.
Oh, the joys. Yes, it is absolutely a fine balance, and that's where working with an OBGYN that you trust, or a provider that you trust, and getting hopefully the results that you are wanting. And so working with them and finding what you like, because like I said, there are so many different birth controls out there, or even doing the natural way and just following it yourself. You just have to be patient. You have to listen to your body, and you have to figure out what's best for you. And there are so many different combinations of medications out there too. There, or different dosage, different brand names, generics, blah, 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 that can make a huge difference. I think I remember one time I went from one generic to another generic, and the way I felt was significantly different, but allegedly the same medication.
Allegedly.
So, allegedly.
Yeah.
So it's worth, investigating.
Definitely.
Yeah.
So we talked about like ovulation, kind of that being like the middle part of the cycle. Yeah. And then you get to the end. So maybe, about 2 weeks later is when we're kind of tracking off to the end. And then that's when you're going to get close to starting your period. So about the week and a half before you start having your actual bleeding, before you start bleeding with your period, there's so many different symptoms that can happen with that. And we touched on a few of them, but like, having breast tenderness is very common. Breast pain, which is one of the most common visits we have for benign breast issues at our clinic.
Absolutely.
Breast pain is a big one. Abdominal aching, crampy, GI changes, like feeling bloated, maybe getting a little constipated or having diarrhea, headaches, migraines. Those are common. Acne, breaking out on your skin is a common change with that hormonal fluctuation before starting your period. Body aches, fatigue, all that stuff. So if you're experiencing that before you start your period, that's very normal. It's a very common thing. It's when it becomes so abnormal, it's affecting your quality of life that, maybe it would be working on birth control or, another medication if you're having rollercoaster mood changes. Like there's plenty of help out there for those kind of things too.
And it's a very real, like there are a couple diagnoses that it goes beyond just like light symptoms. There are where it's much more severe. It's actually like an actual totally separate diagnosis. Yeah,
like you touched on PMS.
Yeah.
And then also like PMDD is another one, which is like depressive disorder that women can get right before their period starts too. And sometimes for those women, we have to do intensive, like an antidepressant, anti-anxiety medication like Zoloft or something like that, whether it's cyclically with a cycle or sometimes even just chronically and long term. So don't be afraid to bring that up if you feel like you suffer with that.
Absolutely. Well, I feel like we've covered, and a lot of us women know our periods.
Yes.
Or we know a lot about it. One thing that we get questions about a lot is perimenopause.
All the time.
All the time. Perimenopause and menopause, of course. And so that is something that Heidi and I have really tried to dive into, and we are working our hardest to understand it and relay the information to you. But of course, for this episode, we're going to keep it pretty simple,
pretty low level, pretty simple.
Yeah.
Hormones, and I've had so many women ask me about also hormones and hormone therapy and all this stuff. And it's a conversation, honestly, I have every day.
Yeah.
And it is such a taboo topic right now in the world of women's health, because there's been, certain studies that maybe have been conflicted, that maybe people don't agree with. So when it comes to like risks of cancer, obviously we're a little bit on that side, and that's kind of where our brains are at. But is there benefits to hormones for a specific woman in a particular situation, by all means. And can it be helpful in certain situations? Yes. So we're not opposed to it, but we're not going to really dive into that today. But hopefully in some future episodes, we'll dive further into like hormone replacement therapy and that kind of stuff.
Agreed.
But I think I can speak for both of us on how we feel about it in that sense. But yeah, perimenopause can be a rough time. Perimenopause too, like that true close to menopause, is really hard for a lot of women. A lot of women struggle with that. Perimenopause really hits, it can hit, most commonly I would say perimenopause in terms of symptoms is really starting maybe about mid 40s.
Yeah.
But it could start from age 40 and it can last until, after age 50, 55,
absolutely.
58. But most commonly kind of riding right there in that like mid 40 range. And then what's happening is like women are running out of eggs. So you're kind of running out of eggs. And so you're having weaker hormone signaling to your ovaries. And then you're not ovulating as you used to because things, as Cassie had put it, which I liked it, are kind of like puttering out. Like it's just kind of like a car with like less gas. That's like, I can't get down the road.
Sometimes you're releasing an egg, but not every time. And that's why sometimes you might get a period and then you'll go months and then you won't have one. And then you might get another one. And then your cycle might be really messed up. And then you might have a little bit of bleeding or you might have a lot of bleeding. And so whenever your periods start to get very irregular and erratic like that, you're most likely perimenopausal.
And too, it tends to go with symptoms that you experience as well too. So we kind of talked a lot too about like those menses type of symptoms, like what you get around your normal periods. But with like perimenopause, things can kind of just go like haywire. Like you can have like some drastic mood fluctuations. You can have, like she talked about with the periods, like they're so erratic. So you may have like so much bleeding and maybe you bleed like twice a month and it's like super heavy and then you might not bleed for 3 months.
Yeah.
And then it's like, well, what the heck happened? And then the next period might be super light. And so periods can be funky, skin changes, like you get like dry skin,
I've
hair,
a lot of dry
nails,
dry skin,
weird hair growth.
Yeah. Vaginal dryness is huge too. I find not a lot of women want to talk about vaginal dryness, but that is a big one that can be quite uncomfortable.
And with that libido, like your libido, your drive to have sex is just kind of dropping off, which can affect a lot of women too.
Absolutely.
And sleep. I've had so many women that talk so much about insomnia and sleep issues and trouble sleeping. And that's honestly like, that's probably one of the big ones I see when it comes to going through the hormone changes with perimenopause and menopause.
Yeah, absolutely. And it's either like you can't fall asleep, you can't stay asleep, or you're getting woken up by night sweats. And so there are medications out there to help with that. And they are non-hormonal medications. However, like Heidi said, if your symptoms are very severe and you don't have other risk factors, it is something worth talking about to your OBGYN or someone that you trust, and maybe hormones wouldn't be a bad idea for you because quality of life is really important.
It is.
None of us healthcare providers want you to suffer. But if there are other alternatives that are non-hormonal or less risk, we would, of course, prefer that.
Yeah.
But
like, let's say you just struggle with like hot flashes.
Yeah.
There are medications out there that can help you with hot flashes and how to get through that are not hormonal based too. That you could at least try to start with.
Yep.
On that point too, with the hormone replacement therapy, we talked about the standard time frame for going through this, like kind of like mid 40s to 50. Really, 40 to 50, honestly, kind of perimenopausal time frame. But if you stop having periods before age 40, that's actually considered ovarian insufficiency, which means things have really stopped out
way
a lot
too early.
Yeah. Way earlier than we expected or want to for you. And most commonly with those women, a lot like HRT or hormone replacement therapy is something that would be a good consideration because that's such a long time, especially if you don't have any other risk factors, no breast cancer history or anything like that. But for those women, that would be probably a good option to kind of help bridge that gap to true menopause.
Yeah. And we say like, then they have much more of a reason to be on hormone replacement therapy because it's truly replacing hormones. And so we would prefer you to be on hormones longer into your 40s because then that can help prevent or reduce your risk of osteoporosis, heart disease, and brain changes as well. But that being said, also don't want you on it forever. Usually the recommendation is until the average age of menopause, which is 51. So if you stop having your periods at 38, then it's very reasonable to be on hormones until 51.
Yeah, that's a really long time.
Completely fine. I will say too, a lot of women have also had their ovaries removed. And so technically that is considered surgical menopause. If you had your ovaries removed at 38, absolutely, you can be on hormones until 51. I have some patients too who have had their ovaries removed in their 40s, and I still think it's okay to be on hormones until age 51 or so. And then depending on symptoms after that. Yeah.
And that's the thing too, like most of those women, they go through surgery and they might not even like know until they start experiencing these symptoms.
Yeah.
Which can be terrible. And then they get on these hormones, but then maybe nobody's ever talked to them about getting off of it, like down the road.
Yeah.
And
we
so
see that a lot.
Keeping that in the mind that like, okay, the average woman hits menopause around, that 50 time frame. And so thinking about it and knowing about it, like, oh, hey, I think trialing off of these and kind of taking a little test run to see how things go would probably be a good idea, just to see how you're functioning at that point in your life. Because we don't want you to be on them forever.
No. And I should clarify too, when I say removing the ovaries, I mean both ovaries.
Yes.
If you still have one ovary, then that one ovary will pick up the slack and will start to produce enough hormones that you won't necessarily notice a difference. But if you have both ovaries removed, then you do not have any, or your amount of hormones has gone down significantly.
Yes. On the flip side to that, if you had just a hysterectomy, meaning they only took the uterus and they left those ovaries behind, you're still producing hormones. Or even if you had an ablation where they just kind of like burn the blood vessels in the uterus, if you're having like really heavy bleeding or something like that, those ovaries are still there and they're left behind. And so they're still producing those hormones. So although you might not have a period or a cycle, if you're curious about where you are in perimenopause to menopause, recommend talking to your healthcare provider about, checking labs and following labs, especially if you're maybe teetering a bit with having some of those symptoms related to perimenopause and menopause. It's always okay to kind of just bring it up, check it out, and kind of see where things are at, especially if, you're feeling one way or another.
Yeah. And so most commonly the two labs are FSH and estradiol. And so those are a couple hormones that tell us, okay, well, is an egg actually being released? And so you can have varying lab values, but you do tend to have to repeat those labs as well, because like we said, it's not a steep drop off of losing all your eggs at once. It's a teetering. It's a
putter.
Or a
putter.
Sputtering out of those eggs. And so your body is trying to release the eggs if there are any left. And so then menopause itself is you're out.
Yes. So menopause, when we get to menopause, that means you have not had a period for 1 full year. So 1 full year. And this is if you have all your lady parts. You got your uterus and your ovaries down there and you've been having cycles, normal. 1 full year without a period, you have reached that check mark box of menopause. And then that's kind of when you get to say, okay, like complete cessation of menses, your menopause. And then we go into then that postmenopausal time period thereafter. And so all those little symptoms we mentioned too, with like the perimenopause, they can ramp up a bit and get even a little bit more severe by the time you like truly reach menopause. Like maybe those hot flashes have just taken over your life and you just can't sleep and nothing can happen and all that stuff. So that can escalate a little bit, but we do tend to see those improve as a woman reaches menopause and goes forward a few years after that.
Yeah. And like we said too, like with the birth control, like coming off of birth control or hormones, it takes your body time to adjust. Same thing with this. It takes your brain a while to adjust to its new normal, and especially your temperature control center, which is why a lot of women have these hot flashes. It doesn't quite know how to regulate its temperature as well without that estrogen, and so that can take quite a bit of time. Hopefully, though, once you reach that benchmark of menopause, the symptoms do improve greatly. Or they improve greatly or they go away altogether.
And that was the ideal situation.
That's ideal. Yes.
I know a lot of women in my life who that's kind of what happened with them. You know, they reached menopause, struggled maybe a little bit, and then, you know, they did well maybe that 2 years after, but that's not the case for everybody. Everybody is, like we've said multiple times, every person's unique and everybody is so different. But when we get to that postmenopausal time frame, there are things that we do worry about. And so with estrogen, it helps our bone density a lot as we're younger and in our hormonally active years. So when we reach that postmenopausal time frame, there's, you know, a big drop off by the time you're postmenopausal. And so the risk of bone density loss is so much greater, which means you have a higher risk to have osteopenia and then osteoporosis, which is even worse, where you're at a really high risk to fracture your bones or fall and break your arm, break your leg, what have you, which can be really dangerous and detrimental for women. But there's also a risk of heart disease, cognitive decline, so like memory impairment, brain fog, urinary issues like incontinence and UTIs and things like that. Depression. Mood.
Depression, prolapse, and it can be prolapse of the bladder or uterus just because of loss of elasticity in your tissues.
Yeah.
So
hopefully those things don't happen, but they're just those risks that we think about. And there are ways that we can help decrease the possibility of those happening so severely. So, you know, most women, when we get close to, you know, that menopause time frame, we highly recommend getting on a calcium and vitamin D supplement because it helps with your bone health. But one of the best things that helps too with like bone health particularly is exercise and movements that are going to help stimulate those bone cells, those like healthy new bone cells to grow. And that's like vibrational movement. So like walking, anything that pulls on the bone too. So like strength training builds those muscles, it pulls on the bones. I've personally had a patient who was on a medication for her breast cancer, which was endocrine therapy, blocked the hormones, and her bone density was bad, and she was told she needed to be on injections, and she said, no, I'm not going to do that.
Injections to improve
her bone density, which is a medication to treat bone density loss. Completely changed her lifestyle, started exercising regularly, working out. I think she does 4 days of weight training, regular cardio, and she completely reversed her osteoporosis and is normal bone density now.
That's incredible.
And she's on this medication.
Yeah.
Still.
That's very impressive.
It is impressive, but yeah, it's a mindset change. But too, like with that can also help with brain function and heart disease and things like that as well too. So
yeah. So you're not treating one thing. You can treat multiple things by doing that. And so that's where Heidi and I will always preach, be more active. Really pay attention to what you're eating because it can make a big difference.
Definitely.
One more thing that Heidi and I preach on a lot is if you are having any sort of vaginal bleeding or change in discharge after menopause, seek out medical attention because, as we were both previously in gyn-onc or gynecology oncology, that could be a sign of gynecologic cancers, more specifically uterine cancer. And so thankfully uterine cancer usually has a decency of bleeding, but don't expect like a period amount. It could just be a few drops. And so I have had women tell me before, well, I just thought, I just had a period come back. It's just normal. No, ma'am, you haven't had a period for 5 years. That's not normal. So then that is something to absolutely bring up to your provider, so then they can at least do a pelvic exam, just look inside and make sure everything's okay, but also most likely a vaginal ultrasound.
Yeah.
As well.
It would not be our due diligence if we did not bring it up.
It would not be. It would not be.
We do not want you to sit on that one at all, ever.
But yes, that is our due diligence or our PSA for today. Anything else to add to what we have said?
I think our goal today was really just to kind of start the discussion about menstrual cycles and kind of what that entails now. Like I said, there's so much taboo. I don't even want to say taboo. There's so much. It's a hot topic with hormones.
Very much.
And I think that it's not just going to be like a one size fits all or what one person tells you is the end all be all. I think it's a very calculated decision when it comes to hormones and hormone replacement therapy. And it's not something to take lightly. And just because maybe you listen to a podcast about maybe somebody who is very passionate about hormone replacement therapy and they recommend it for every single person, no matter what have you. No, I really want you to think about it. And really have a long discussion with your own providers and, do your own research and see what's out there too. But that's kind of like why we mentioned some of the things we do on here, because it is not as just easy and straightforward as you might think it is.
Correct. Yeah. That's a good way to put it. It's not a one size fits all. It's very complex. And in the medical community, it's also very controversial. It depends on who you talk to. There are different studies, but to be quite honest, there's not enough studies.
No.
And not big enough studies. And I do think as we move forward, we will start to see so much more come out about it. And they're also a little bit more hesitant to do trials on women, especially when it comes to if it does put you at increased risk for cancers. But anywho, I think there's definitely more to come, and it'll be interesting to see. Yeah,
like I always say, practicing medicine it's an art and it's an ever learning experience. It's something that it just evolves with time. I mean, even where we were 10 years ago has come a substantial way too. Yeah. So it's something I think that we'll get answers as time goes along to better answers and maybe better direction. But like Cassie said, there's always studies, there's always new data coming out. And so hopefully maybe we'll get even more direction sooner rather than later. But we also plan to have some guests on here that may have more experience in hormone replacement therapy, pelvic health, birth control, so many different things. So as always, please let us know if there's anything specific you guys want to hear about, what you want us to talk about. We have had requests for hormone replacement therapy, so
we will get to that. We are really trying to do our research so then we can have a well-rounded conversation for what that might look like.
Yes.
And just understanding it in its entirety as best as we can.
Definitely. As always, don't forget to follow us.
Give us a like. Share our accounts.
We're on Instagram at mindfullywoman, all lowercase. On YouTube at mindfullywoman, all lowercase. Our email is mindfullywomanpodcast.
Beautiful.
At gmail.com. And we would love to hear from you guys.
Yeah. Love to hear your feedback. Any topic suggestions, any questions, or if you just want to tell us how much you love us.
That would be great too.
Very greatly appreciated. All right.
We'll see you soon.
We'll see ya.
Ta-ta.
Ta-ta.
The information that you hear on this podcast is not a substitute for medical advice. As always, please seek out personal care and advice from your medical team.